Welcome to the Antenatal Assessment. So in this one, hopefully you guys will go through the presentation by itself and look at those videos, those delivery videos. Usually I look at them with you and I'll try to explain them as well as I can, but those videos will help you sort of understand the different procedures and things we do together. So we're looking at antenatal assessment. These are things that we're going to look at around delivery. So let's get started. So high-risk mom. So what does a high-risk mom look like? So when we're looking at this, it's important that you realize there are certain things that's going to be considered high-risk deliveries, like if the mom's had a previous preterm baby, or a maternal age over 35, or when we're seeing moms that already have underlying significant health issues, diabetes, things like that. Those are all things that can factor into a high-risk mom or high-risk delivery situation or high-risk pregnancy situation. When it comes down to it, there's also things to consider when you have certain pregnancies where mom got all the prenatal care in the world, got all the right nutrition in the world, stayed away from the right things, took the right things, and somehow something happens and that mom has a high-risk delivery. And those things just happen. So it's important you realize there are certain things that we'll look for, and you'll see certain themes when we're going through this on high-risk pregnancies and high-risk deliveries ultimately down the road. But it's important you realize that any mom at any time, and this is not a scare tactic or anything, but any mom at any time can develop a high-risk pregnancy. And it's just something, like I said, it can happen because of pre-existing conditions, or you could have something where mom had perfect health, baby had perfect health, and then all of a sudden something happens, and sometimes they're very unexplainable, like preeclampsia, and it can change things. It can change to a very high-risk pregnancy and high-risk delivery when it comes down to it. So when you're looking at a high-risk mom and a high-risk pregnancy, there are certain things that we're going to look at to sort of help us determine what type of staff we need there or anything like that. But understand, at any point, at almost any pregnancy, even though statistically it's small in North America, you can still have a high-risk pregnancy and a high-risk delivery from almost any situation. One of my worst, or I shouldn't say worst, and one of my most memorable, we'll just use those terms, one of my most memorable deliveries was a kid that was term, and they came into induced labor because the kid was just taking its sweet time in there before it came out, and sure enough, something happened at that delivery that made it a high-risk delivery. So it's something that you just be aware of. It can happen at any time as far as from your side of things. Statistically, overall, in North America, this is not something that happens in great quantities. So I'm not here to scare you. I'm here just to make you prepared that sometimes the most healthy things in the world, something just happens, and we just got to be prepared. That's what we train for. That's what we work for. And you're there to be a calming presence in the middle of this chaos. And that's the whole point. That's what we're looking for here. So understand there are factors and themes of what a high-risk mom does look like. And pay attention to those, right? Those are things that you should take note of. If mom doesn't know the age of the child, she was a drug abuser, or currently is high on drugs, and drunk, and all those things. Those are stuff you want to pay attention to, and I'm not making those up out of the blue. Those are things that I actually have seen. So I just want to notice out there some of those common themes and how that could really ultimately affect the baby and the delivery and everything that we do around that situation. So be aware, it could be out of the blue, or it could be something we sort of see from a distance, but you got to be prepared for it either way. Maternal factors that make for a high risk. Hypertension is going to be one of the big ones, and this is a big problem in North America. Here's the thing, preeclampsia, they still do not know what causes preeclampsia. Mom could be perfectly healthy, normal blood pressure, no medications, and somehow during her pregnancy, she develops high blood pressure, right? So preeclampsia, when we're looking at eclampsia, this is where we have preeclampsia, eclampsia, and HELP, and this is where we're going to talk about these three. And preeclampsia is going to be a big thing to pay attention to. Odds are you either know someone, or there's whether or not they've told you before. Odds are you probably either know someone or know of someone that's had preeclampsia with their pregnancy. It's one of those things that are out there, and they still don't know exactly what the cause are. Or cause is, I should. So as you can tell, eclampsia is a big issue. Eclampsia itself is the onset of seizing. So if a woman is pregnant and she's actively seizing, that means she's crossed over into eclampsia. So pre-eclampsia means usually the hypertension. They usually have elevated urine proteins. They're gonna do a 24-hour urine test usually. There's a shorter, smaller test they can do. It's not as accurate as a 24-hour urine test, but they're going to do that. Elevated proteins in the urine. They're going to look at her blood pressure, of course, has got to be elevated, and she's got to have edema, like pitting edema. Other things that could go along with that is clonus. That's where they have that shaking as a deep tendon reflex as well, and that shaking, it's all part of that preeclampsia procedure. And the big risk here is the only thing that can happen with it, well, not the only thing, but the big thing that we're worried about is mom going from preeclampsia to eclampsia, where she's going into seizure. And of course, your oxygen requirements during a seizure go up. You can get hypoxic. You can do a lot of bad things during a seizure. Of course, that's bad for her brain, things like that. So there's a lot of bad issues when we're looking at preeclampsia. So her blood pressure will be high. Her urine proteins are going to be high. And she's going to have that pitting edema, which is normal to happen with pregnancy anyway, but that's part of it as well. And usually neurological symptoms are going to be part of it. Extreme fatigue, headaches, of course, with the high blood pressure, those are all going to be part of it. And so, like I said, there's no known cause for preeclampsia. Some people think it is hormonal, and it's been around for, it's been described in books by Socrates. It's been around for forever, but there's no actual known reason for it. Some people think it's hormonal. Some people think the baby causes it on mom, like there's some reaction where baby transfers something to mom and then mom develops preeclampsia, or some people think it's mom developing something against baby and that's what's causing it. Whatever it is, the only known fix for preeclampsia is delivery of the baby. So if mom's blood pressure is too high, if her urine protein levels are high, if she has a lot of clonus, if her neurological status is changing, that means that that baby, no matter where they're at, as far as their 23 to 38 weeks or whatever, right? As long as they're past that 23-week part, that baby might have to be delivered if mom cannot be stable. Right? So that's where we might have to go ahead and take a baby prematurely, even though the baby hasn't gone into premature labor or mom hasn't gone into premature labor yet as well. So pay attention. Pregnancy-induced hypertension is another term that you might see out there, PIH. So if you see PIH and preeclampsia, they're pretty much very similar things that you're looking at. And that's something that we need to pay attention to, because if that mom at any point, her blood pressure goes up, her urine proteins go up, she has other symptoms that are going on, we might have to take that baby prematurely, and that's best for both mom and baby's health, because it's not good for baby if mom's coding, right? Baby is living off of mom as a life support system, and if mom as a life support system goes down, that also means baby's going down with her. So that's one of the reasons why we might have to go ahead and take baby early in some of these cases. And that's exactly what happened to me and my wife, right? It was a preeclampsia case, and it's one of the things that we just had to do for the best of both, right? And it was as the safest and best option for both of us, right? So when we're looking at preeclampsia, it's a big issue. And if a mom goes into eclampsia, expect an emergent delivery if they haven't already done one already. And that's the big thing. And don't think that once the baby's delivered, that mom's all out of the eclampsia aspect, because even after the delivery, it can be like a 24-48 hours after delivery, that blood pressure can go back up depending on the type of hormones, things, whatever's causing it comes back in her system. It has a honeymoon and then it comes back up. So if you're working on labor and delivery as the NICU respiratory therapist and somehow you get a call for a code and mom's seizing, this is something that you might want to think about. Even though she's postpartum, this is something you might want to think about, right? Blood pressure meds, did she seize? Is her airway patent, right? You go back into your adult therapist mode until anesthesia get there, until someone gets there to relieve you or to join you in the patient troubleshooting situation. So preeclampsia is a pretty big thing. So we're going to watch mom's blood pressure. We're going to watch her urine proteins. We're going to watch mom's physiological status. One of the big things that we'll do for preeclampsia moms is bed rest, of course, right? We're going to make sure that she's not stressed as much as possible. She might be on observation in the hospital for weeks and weeks and weeks. And it's very sad to see that, but it's very stressful for her and for her family when we're looking at it. And we got to pay attention to being able to recognize when we're looking at a preeclampsia situation, being able to recognize that this mom might feel guilt, especially if this baby's preterm in the NICU. There could be an episode where she feels guilt and emotional attachment, and that's normal. That's something there, but I want you to be there to understand that what you're seeing there is she's feeling a lot of guilt, and we're there to bring calm and presence to the situation. It's not a time to start delivering facts and what their x-ray looks like and what, all this other stuff that's going on. It's there to, be a support or get support for her and or for her family that's there too. So preeclampsia is a pretty big thing. Pay attention to that. If you have a patient that's preeclamptic, one of the things that we might start on mom with preeclampsia is mag sulfate. Mag sulfate's been known to help, it's an IV drip, it's been known to help obviously relax smooth muscle. So it's one of the things we can use for a tocolytic to stop labor, right? It relaxes smooth muscle. Well, the uterus is smooth muscle, right? You might have seen us use mag sulfate in severe asthmatics as well, right? It relaxes smooth muscle. Well, what are the bronchioles? The respiratory bronchioles lined with smooth muscle, right? So it relaxes smooth muscle. So that magnesium sulfate drip not only is good for a tocolytic to stop labor, but it is also used for neurological protection. So when we do that, mom's not going to have a good mental status. She's going to have sort of a aloof mental status while she's on blood pressure medicine, while she's on this, and why she's on monitoring with baby. We're going to watch baby very closely. We'll have that fetal heart rate monitor on her and contraction monitor. Even though they're not having contractions, we'll usually have that fetal heart rate monitor to see how stressed baby is as well when we're looking at all this. Mom goes into preeclampsia, we might still give her steroids if we're expecting that baby to come early. Something we talked about in the surfactant presentation as well. Those steroids will help develop the lungs. So if we do have to take that baby early, then that gives us a better chance at making sure those lungs are fully developed so we can spend less time on the ventilator, so we can have less issues with high pressures and FiO2s and all that stuff. So preeclampsia and eclampsia are very serious issues. One of the things that you might see as well in labor and delivery is something called HELP syndrome, and there's two L's in there for a reason. So when we're looking at HELP syndrome, you do need to know what this stands for. So the H is hemolysis, right? There's going to be a massive amount of hemolysis that's going on. And this is the mom, so she still has the baby in her, and this is mom. So she's going to have hemolysis. The EL, so hemolysis. EL is elevated liver enzymes. Elevated liver enzymes. So we're going to run our AST, ALT, both of those will be elevated, and the LP stands for low platelets. Low platelets. So our ability to clot is going to be affected as well. So that's HELP syndrome. Hemolysis, elevated liver enzymes, and the low platelets. So these are all bad signs when we're looking at HELLP syndrome and a mom. Why do I want to know? Well, it's one of those things that can complicate a pregnancy. And when we're coming down to HELLP syndrome, it's one of those things that's subsequent to high blood pressure. So HELLP syndrome is usually indicating some sort of pregnancy-induced hypertension or preeclampsia, if you will. Right? So usually when we're looking at this, it develops before the mom's 37 weeks in gestation, right? Or before the baby's 37 weeks in gestation. So this can be a sign that we might have to have a baby that comes in early, or a sign of preeclampsia as well. So if you see HELLP syndrome, that sort of falls into this whole realm of preeclampsia as well. So I do expect you to know what HELLP syndrome is. I do expect you to understand what preeclampsia is, or eclampsia is, that seizing activities, that high blood pressure, elevated urine proteins, as well as the pitting edema, which is normal for especially third trimester of pregnancy, but that edema, the pedal edema, right? Their legs, their ankles, so on and so forth, when we're looking at it. And this is very serious because mom is baby's life support system. And so if she develops clonus, if she develops change in neurological status, things like that, we might have to take that baby early. So you should be ready and understand that this baby could come at any time. Other maternal factors that can affect the baby and the delivery and everything else that will happen afterwards. If the mom has diabetes, pre-gestational or gestational diabetes, so whether they developed it in pregnancy or they had it pre-pregnancy, that's be the one things that you need to pay attention to, even if you don't go to the delivery room. Why do you need to pay attention to it? Because when we're looking at this, the baby is going to be producing a lot of insulin, right? The baby is producing a lot of insulin. So when when the baby is delivered, when the baby is no longer in utero, and now the baby's outside, the baby's still going to be producing a lot of insulin, which means that their blood glucose could go down dramatically, right? That means that baby can sort of check out, right? Low blood sugar level. Do you guys feel good and ready to go when you have low blood sugar? No, you don't. You don't think well. You don't act well, right? That's those old Snicker commercials, right? You don't think well. You don't act well, right? So when you're looking at this, it's a big issue to understand that there was gestational, pre-gestational diabetes, because for baby, if you're NICU team here, that means you're just going to watch their blood sugars pretty closely for that first 6 to 8 hours, because that baby is probably producing a lot of insulin, and so that might affect their blood sugars pretty significantly. So we might have to give them some D10 or whatever it is, keep their sugar up, start feeding them, right? Start doing all that stuff as soon as we can to get that as a factor. Now, also remember with diabetes, whether it's gestational or pre-gestational, those babies tend to be LGA. So this is large for gestational age. Well, why is that a big issue? Well, when we get into the labor and delivery presentation, we'll talk about how the head might be too big to come through the pelvis, and so that kid might have to go as a C-section, which is not the preferred route, especially unless it's like a repeat C-section, like a VBAC. So when we're looking at this, the large for gestational age, babies can have some issues as well with labor and delivery. They can be caught up in the birth canal more. They can have a lot more issues with the delivery experience. Not only to mention mom might have some issues trying to push out a baby that's large for their gestational age. So when you look at some of these LGA babies, you'll hear babies that are born at 10 pounds and so on and so forth. Those are big babies. They're LGA, large for their gestational age. And just because they're LGA doesn't mean that they're fully developed. They just mean large for their gestational age. And so it's going to be one of those odd things to work with when you go to a delivery and a baby's LGA and they're having to use forceps or a vacuum to help do the vaginal delivery, or we have to go to a C-section because the baby is CPD, cephalopelvic disproportion. In other words, the baby's head is too big to go through the pelvis. So that's one of those things you just got to be aware of. Like, why am I at this delivery? Those are one of the questions you got to ask when you go to a delivery. Why am I here? right? And then they say, oh, CPD, cephalopelvic disproportion, was the mom diabetic? Should we be looking at blood sugars? Things like that. It'll help you understand the situation and take care of the baby better afterwards if we know that we need to be checking their blood sugars. If we know why we're at the delivery, oh, the baby's just LGA and there's no blood sugar issues, like there was no diabetes, the baby's just LGA, then I know, okay, that's something that we'll have. We just don't have any thoracic squeeze if we're doing a C-section, right? So we just got to watch that fetal lung fluid and breathing initially. All right, so some other maternal risk factors, infection. And infection is going to be one of the big things that can actually cause the baby to be preterm. So when we get to the final part of this presentation, we'll talk about what is preterm and what can cause a preterm delivery. Well, if mom has infections or baby has infections, those are all indications, or sorry, not indications, those are all things that can cause preterm labor and or preterm delivery ultimately. So group B strep, GBS, group beta strep, so we call it GBS positive, GBS negative, so we just call it GBS. So if you're looking at a labor and delivery board, you guys are out there for clinicals and you're able to go to deliveries, and they say they're GBS positive or GBS negative. GBS is done later on in their gestation, so I think it's usually later than 35 weeks, somewhere in that area. And they'll do a GBS test. I won't tell you how it's done, but it's done. It's a little graphic if you look at how it's done. And if they're group beta strep positive, that means we're going to treat mom with antibiotics. Group beta strep is a bacteria, and so it can eventually cause things like neonatal pneumonia, things like that. It can be an infection risk for baby, both inside as well as when the baby's born. So we're usually going to treat with antibiotics. When the baby is GBS positive, GBS negative, not a concern for us. The test only lasts for, I think, about 2 weeks, and then they have to retest it again. Once again, unless you're becoming a labor and delivery nurse or you really want to know, I'm not going to tell you on this format on how they do that test. If mom has herpes, actually that's a sign or an indication if she has active herpes to do a C-section. That's actually a reason why some babies, especially their prima gravida, it's the first labor and delivery, if there's active herpes, then they will go ahead and elect for a C-section, so that way the vaginal canal won't cause infection on the baby. So you'll see that, and you'll see the herpes on the face and things like that. And then that's in our neonate infection presentation. We'll go over that as well. So that's actually an indication for C-section if mom has active herpes. Things like HIV. Now, HIV we'll talk about also in our infection presentation. HIV is going to be one of those things that they're doing better and better. They can still treat mom with antiretroviral medicines, and the transfer rate on HIV babies, even vaginal deliveries, is still extremely low. Right, it's in the single-digit percentages the last time I looked, and you guys can look this up as well. And when we're looking at this, it's gotten lower and lower. So these are all things that will or can factor into this. Hep B can also factor into it. Make sure mom has all of her shots, of course. But GBS is going to be one of the big ones that you'll see out there in the labor and delivery unit. If mom's GBS positive or not, you want to know about that because that could transfer over to baby as well. Right. Other maternal things that can happen is we can have a change of integrity of the uterus. So cervical incompetence is just a fancy word. Usually means that like a shortened cervix is one of the classic things out there. So when we're looking at a shortened cervix, that means the baby's head, and there might be better pictures of this, but the baby's head is sort of at the opening of the cervix, the baby's head down, or their feet are down. Something's at the opening of the cervix, and the cervix can expand pretty easily. And normally it shouldn't do that unless we're getting towards delivery, right? Until we're getting towards the later stages of labor. And when we're looking at cervical dilation. So if the cervix is short, they might put in what's called a cerclage. Now, a cerclage is where they can pretty much just sew up the os, or the opening of the cervix itself, to help prevent the baby from sort of peeking through, like a foot coming out or a hand coming out or anything like that, that could cause a premature rupture of membranes. And then remember, a premature rupture of membranes can also cause an infection or put a kid prone to an infection. So they might put in a cerclage, and there's videos on that. I don't think I put them in your regular presentation, but you might see that as well. A mom might come in at 24 weeks, and you'd be like, oh my goodness, why is that mom here? And they'll be like, oh, the cerclage. I'm like, okay, whew, thank goodness, because I don't want to go to a 24-week delivery, right? It's not great. So that's where we're looking at cervical incompetence there. They can fix that, and then as they get closer and closer to term delivery, they can remove the sutures for the cerclage. The placenta can have issues. We can have what called a Placenta Abrupto or a Placenta Previa. Abrupto placentae is where the placenta abrupts. In other words, it detaches from the wall of the uterus. This can be a partial abruption or full abruption. Partial abruptions, they're not necessarily, it depends how minor they are, not necessarily an indication for emergent delivery. Right? If it just tears a little bit, there might be some maternal bleeding. Obviously, that needs to be checked out. But when we're looking at it, as long as the baby's vital signs, as long as the baby's biophysical profile is doing well, then we should be okay. So the abrupto placentae, if it's a partial abruption or very minor partial abruption, may not indicate much to us besides monitor on the fetal heart rate monitoring and then do biophysical profile scores, non-stress tests, things like that. But if it's a full abruption, that means the uterus and the placenta aren't attached to each other anymore. And that means there's no life support going to baby. And that means that we need to deliver that baby. Placenta previa means that the placenta is covering the opening of the birth canal. In other words, it's covering the opening of the cervix, and so the baby cannot be delivered vaginally. The placenta is sort of covering, got attached to an area very close to the opening of the uterus there, and so the baby's not able to come out. So placenta previa is actually one of the indications for a C-section, just like an abrupted placenta. Now we're talking about a complete abruption of the placenta would also be an indication for a crash C-section. All right, so placenta previa, it's not an indication for a crash C-section, but it's an indication for a C-section if the baby cannot be delivered through the birth canal because the placenta is sort of pretty much covering it. Now, early on in pregnancy, it's normal to have like a little bit of a placenta previa, but as you get more towards third trimester, that's when the uterus should sort of start to expand, and it should pull it away from that opening of the uterus there. So that it's not uncommon to start a pregnancy with a partial placenta previa, and then have it sort of move away as the pregnancy advances. So placenta previa and abrupto placenta are two things. The placenta accreta, I should mention that as well. The placenta accreta is where the placenta and the uterus have too tight of a connection. Now you're like, how can it be too tight? In other words, they're pretty much fused together. So the third part of delivery, so we'll go through the stages of labor and delivery. The third part is delivery of the placenta. So the thing there is some of the placenta may be left intact. You're like, Derek, I don't need to know this. I'm like, you do need to know this, because if some of the placenta is left intact in the uterine wall, even after baby's been delivered, mom can continue to bleed out. And it can eventually cause what we call a code white, which is a maternal bleed, which means mom's going to be hypovolemic, which means she's going to be anemic, which means her oxygen levels are going to be low at this code. Her blood pressure is going to be low at this code. You're going to need to give her fluids. You're going to need to give her blood. She might need CPR, right, if it goes into this whole severe code white situation. So if you're going to be up there, you're going to be in that area of labor and delivery. I want you prepared not only for baby, and that's what my primary purpose for this course is, but also for mom too. Both before, during, and after delivery, you might be the closest respiratory therapist to that mom. right? So I'm here to help you in that area too. I don't want you to be unprepared to go to a labor and delivery room and then mom needs your respiratory therapy services, right? I had one of my cases that I remember off the top of my head. I went to a C-section and the baby needed to go to the NICU, and so we got the baby to the NICU, and baby was doing very well there. And then not more than 24 hours later, I was on the next day in the NICU, and mom had a code type situation, and I was able to be the first RT there. I performed some intervention, went down to the ICU. She was went into severe ARDS, and she was one of the people we enrolled in one of my studies. And she ended up doing really, really well. And one of the cool things, or one of the neat silver linings of that whole situation, is very sad. She made it. She did great. She walked in. She made all of her subsequent appointments with the OBGYN. The OBGYN would always keep me updated about her and her baby. She's like, no, they're so amazing. You should see them. And right, one of the silver linings there was the OBGYN got to see a whole different side of the respiratory therapist. Got to see a different side of what we do outside of just helping wipe down the baby and helping putting him on CPAP and all that stuff. She got to see a whole different side of what we do as a profession. It was really cool to sort of see that development, and she had a lot better understanding. She would send residents with me after that and be like, hey, you should go follow him in the ICU and see what they do down there. And they do a whole bunch of different stuff with lungs and hearts and all that stuff. So little sidetrack there, but understand, I want you to be prepared for mom as well, right? To take care of mom in this whole situation as well. So placentas can have their issues, whether they're previas or abrupted or partially abrupted. The cord can also have their issues. The number of vessels is going to be something that we pay attention to. We want to have 2 arteries and 1 vein. So the 2 arteries are very small and thick, and then you have this big floppy one, right? And this is going to be the umbilical vein, and these are going to be the umbilical arteries, right? So you always want a big floppy and 2 thick ones, 2 tiny thick ones, right? The reason why I use the word big floppy is it's stuck in my brain, and there's nothing gross behind it that my brain is thinking of, but the big floppy is where you would put your umbilical venous catheter for fluids. If a baby had was bleeding out or anything like that, that's where you're going to put for fluids and for drugs, for epinephrine, you name it. That's where you're going to put it, as in the umbilical vein. And then the length of the cord can be an issue too. And we can even have nuchal cords where the cord wraps around the neck of the baby, or the baby can tie the cord into knots, right? There's tons of Google images of knotted umbilical cords and all that stuff. Go have fun with that right now. But when you're looking at that, the big floppy umbilical vein is the big thing to pay attention to in a delivery if we have to give fluids. That's what we're going to do here. And the reason why I have this picture here, I had a baby, we went to delivery, it was a term delivery, and that's the one I was telling you about earlier, where the mom just needed to be induced for labor, so nothing I was involved with at all. And for some reason, when they induced labor on this term baby, the cord separated, right? And that's hence that picture there. The cord separated and the baby lost a lot of blood. Well, mom's losing blood too. So they took mom for a crash C-section. That was one of those you get paged overhead situations. And crash C-section, term kid, and kid was just hypovolemic as all get out and pale. And we got the kid intubated at minute 26 seconds. We got ventilation going. The nurse practitioner started putting in the umbilical venous line. And the first thing we did was we tried to give epi down the ET tube, which was not very successful, because that actually caused pulmonary edema and increases PVR, which then keeps the PDA open, which then means there's still more shunting going on, but that's a whole separate thing. I won't get into that yet. But once she got the umbilical vein, and we pushed epi, and that didn't do anything because the kid was hypovolemic, so then we pushed volume, right? Remember, it's 10 mLs per kilo, and that kid was like roughly 3.5, so 35 mLs. So 10 mLs per kilo, so 35 mLs of fluid, of sterile saline. And once that fluid sort of got into that baby system, that's when we got her around. And so she had a lot of issues because her PVR was so high, she was shunting so much. We took her over and put her on the oscillator with the nitric oxide to help vasodilate, which would then decrease her PVR. And we eventually had her flown over to a different, our level 4 NICU, because she had so many issues. It was one of the neat things because eventually I got later word that she was nippling, she was doing fine later on, but it was really neat to sort of see a baby that sick, that dramatic, that difficult, and then to be a part of getting that baby to pretty much a normal, healthy status is just an amazing thing. And I hope you guys sort of see value. I know you could have this look on your face when you're thinking about going to a high-risk delivery and using all these advanced skills, but there is great reward working in this area, and I just hope you see it. I hope you don't have that look of fear all the time. The more you learn, the more you get oriented, the better you'll have. Of course, we all have these moments, but then you'll see that that kid at a NICU reunion is looking fine, doing fine, and you'll be just amazed. All right, off of my little high horse there. Membranes and fluids, this is pretty important to take note of. Premature rupture of membranes can put that kid at higher risk for infection. So we might do prophylactic antibiotics for that kid for the first 24 hours or so, just to be sure of things. An infection on top of a premature delivery can be one thing too much, right? So they might elect to do 24 hours of prophylactic antibiotics, just broad spectrum antibiotics. Some facilities or neonatologists may not. That's just depending on your facility neonatologist. If there's too much or too little amniotic fluid, that can be a bad thing as well. We talked about too little amniotic fluid. That oligomhydramnios means that their fetal lungs may not be developed because there wasn't enough pressure in their lungs. Too much could also be another issue as well. So when we're looking at this, we've got to have a good amount there. And we'll look at amniotic fluid volume as part of the biophysical profile as well, and we'll get into that later. All right, maternal factors. The age of the mother can play a factor if she's less than 17 or over the age of 35. Less than 17, usually that's when we're worried about their pelvis development as well. Now, I'm not an OBGYN, never will be, but when we're looking at this, their pelvic development, we had a 13-year-old we had to go to a delivery. She was in active labor and she was delivering, and the 13-year-old, they had to do a C-section with her because her pelvis was too small. She wasn't developed enough to have a vaginal delivery, so we had to go and do a C-section. So there are risks of, especially nutritional, if mom's over the age of 35, I think her risk of deliveries and everything does change. It's not huge. It's a little bit of a change, but we just got to be aware that maternal factors, like age of mom, can impact sort of the health of baby. If mom has osteoporosis or other things going on, or hypertension that she's developed, those are all other factors that can happen besides the age of mom. Previous pregnancy complications, if their previous baby was preemie, that can also mean that this subsequent delivery may be considered subsequent baby may be considered high-risk pregnancy because the previous one went preterm. That means the subsequent one might be also have more of a likelihood of also being preterm as well. So previous complications, if they had to do a C-section, usually not a big thing. We have to look at a vaginal birth after C-section. It's called a VBAC, vaginal birth after C-section. So it's a VBAC. And the reason why I bring this up, and I bring all these up for a purpose, VBAC, I didn't know what this was when I went out of school, but when we look at a VBAC delivery, vaginal birth after C-section, why is that risk? Why does that matter to you? Because if mom's attempting a vaginal delivery after a C-section, if the uterus didn't heal quite right from the first one, or the subsequent baby is putting too much stress on the uterus, it could actually cause that incision site or that former C-section site to abrupt. In other words, it could cause the uterus to tear and abrupt, cause maternal bleeding. And obviously, mom is also and especially the uterus is also baby's life support system. So that could be a very different situation. Now, there are some states, and I'm not sure if it still goes on, where people aren't allowed to attempt a VBAC. But if you are in a place that attempts VBACs, and I think Colorado lets you attempt VBACs still, just understand if there's a maternal bleed or anything like that, that's probably, that might be one of those things that makes that labor a little bit more intensive, is if there's a VBAC situation going on. Now, the rates, I think the last statistic I looked up of a VBAC is like less than 10% actually have an abruption or something like that. It's not 0, but it's less than 10% can still have the uterus tear. And there's even some C-sections where they're VBACs and they're just failed to progress, right? In other words, they took too long to labor, so they went ahead and went with the C-section. And you'll see what's called a uterine window. And I'm not making this up. You can look this up. It's called a uterine window, and you can actually like almost practically see, it's like a little transparent window into where baby is. It's kind of an interesting thing there. So it tells you how thin or how much stress was put on that former C-section site. So if the mom's a previous smoker, obviously smoking's been linked to SGA babies. So SGA is small for gestational age, and they're also usually IUGR as well. So intrauterine growth restriction that causes them to be small for gestational age. And this is also a known cause for them not only to be small for their gestational age and restricted in their growth, but also to be premature as well. So there's a lot of issues that goes on there. That's why maternal smoking is a big no-no. Don't do it. When you're looking at that, it's going to be one of those things that is going to be a factor in why this baby is premature, why the baby is small. But these are all known associations that are out there. Maternal drug use is also a known a cause for premature delivery or premature labor as well. So these are things that we got to be aware of. Even though we've talked about it in the surfactant PowerPoint that like heroin use and cocaine use are vasoconstrictors, and they cause stress and they might help the baby's lungs develop, still can make that baby be delivered preterm or go into preterm labor. And these babies can still be malnourished, especially if mom is malnourished. And when we're looking at drug abuse like that, that's something that should be considered as well. The malnourishment of the baby can cause a lot of stress and lack of development and cause them to have IUGR, which then cause them to be SGA. So we just got to be aware of all this. So how do we make sure a baby's healthy in utero? Well, ultrasound is going to be one of the big things. It can give us a view of the baby. We can look at a 4-chambered heart. We can look at if there is a CDH. We can look at a bunch of different things. We can look at the renal developments going well. Right, and that's the whole thing. Hopefully you can sort of see the kids. I love looking at these because the more you look at them, the more you understand. You can see the eyes, the nose, and the mouth. You can see an arm there. You can see another arm that's by the head. You see the Buddha belly. It's going on. Obviously the skull and everything. You can see the brain development. You can see a lot of good stuff on ultrasound. Fetal breathing motion is something that we'll look at, especially when we're looking at the biophysical profile. That's going to be something you want to be aware of. Tells you sort of how healthy the baby is or how healthy the kid's doing during the whole situation. So we also can do an amniocetesis. This is where we take a sample of the amniotic fluid. Go have fun looking at pictures of that. It does not look pretty, but allows for the amniotic fluid to see a bunch of different things. We can look at lung LS ratio, right? We can look at lung maturity. In this situation, we can look at bilirubin levels, creatinines. We can look at alpha-fetoprotein levels, AFP levels. Can also tell us, a lot of this can tell us about genetics, presence of meconium. It can tell us a lot of different information. Now, AFPs are optional. That's where people, you can look at stuff to see if the baby's more prone to like Down's syndrome. Things like that can all be part of this whole situation. Amniocentesis is not done with every delivery. It's more like high risk, or not every delivery, not every pregnancy, but it can be done with more high risk pregnancies if there's more benefits that we can have from it than risks. A lot of this stuff can be done with a blood test too. So amniocentesis can give us some good information. However, we have ultrasound, and then we also have fetal heart rate monitoring. And fetal heart rate monitoring tells us a lot about the baby's distress. And so there's a whole video in here about looking at the labor and delivery, the fetal heart rate monitoring to contraction, and why we care about that and what it means to you. And the big thing there is whenever the uterus contracts, the heart rate should slow down on the baby. Right, we're looking at, term delivery. The heart rate should slow down on the baby because everything's contracting. It should slow down a little bit, not all the way, but it should slow down, right? And then when the contraction's over, the baby's heart rate should come back up, right? So we should see. So if this is the baby's heart rate, and then this is the strength of contraction. I'll just put a C. Okay, so the heart rate's here, and then the contraction starts to happen here. So I'm contracting here, the uterus is contracting here, and then when it's contracting you should see a drop in the heart rate. So the heart rate decreased and the strength of contraction increased. Yes? So you should see them come close together during contraction, and then as the contraction subsides, you should see the heart rate come back to normal. Right? That's normal. You're like, Derek, why are you doing this? Trust me on this. You will enjoy this information. It will be very useful to you. Because if you walk into a room and you see the heart rate and the contraction, and you see the heart rate is the contraction happen, and then there's no change in the heart rate, and then the heart rate changes after the contraction with it, then we're going to have to look at things like late and variable decels. And I want you guys to watch that video when we get to that in this course. And that's going to tell us that there could be a placenta issue, there could be a uterus issue, there could be a cord issue, right, where the cord is compressed. So the signs when you start to see those late and variable decels, which is what's happening in this sort of situation, late and variable decels, when you see that, that means to put mom on oxygen. I will repeat that again. When you see late and variable decels, it means to put mom on oxygen, and depending on which one it is, late or variable decels, then that means we may have to progress the delivery as well. Now, it's normal to have one or two of these later variables here and there, but if you get called to deliver, then they say late and variable decels or late or variable decels, then you got to be prepared that that baby could have cord compression, and they might be hypoxic. That's why the heart rate was slow, right? Things like that you need to be aware of. And then if they can, and usually they're pretty good about putting mom as much oxygen. So the idea there is if we increase mom's PaO2 as much as humanly possible, they'll put her on an outer breather, something that's high oxygen. If we increase mom's PaO2 super high, that means baby's PaO2 should be, if there's cord issues or there's things that are going wrong with the uterus and placenta, get the baby as much oxygen as possible, especially if they're being cut off from blood flow, right? So that their idea is they're going to have less chance of an anoxic injury or organ damage for baby if we give mom a lot of oxygen. So I say these things on purpose. First thing you do when you'll see these is they'll try to reposition mom, put her on oxygen. If it still continues, then we might have to look at something like an assisted delivery or something like that, like a cord's compressed or a C-section, something like that might be going on. So fetal heart monitoring, that's what we're looking at here, is the baby's heart rate, and then the other thing on there is going to be mom's contraction that we're going to be watching. And this is normal here. You'll see the contraction increase as the heart rate decreases. Anything other than that, that could be a bad sign. We just have to watch it. Right. So make sure you're watching these. Fetal blood gas analysis during delivery. This is where we can look at baby's distress. If the baby's distressed inside, we can actually do like a scalp pH, right, from the inside. If the baby's in distress, we might be able to get a body part, right? A body part, and look at their pH. If their pH is in an acidosis, and I'll go over that next, if they're in an acidosis, it might indicate that they're asphyxic, right? And we might have to go for an emergent C-section, or we might have to, if the baby's partially through the birth canal, use assisted delivery like a vacuum assisted delivery or a forceps delivery. Okay, stress test and non-stress test. So let's talk about these real quick. Hopefully you know what these are. If you don't, that's okay. A non-stress test looks at baby's heart rate with baby moving, right? So we're going to put the heart rate monitor on there, and we're going to look for baby moving. So mom comes in, she lays down for like 10 minutes or a half hour, and what we're going to look at, hopefully we have a little while to watch, but hopefully we'll see that the baby's heart rate will accelerate when they move around. That's a good, healthy response. Just like you, right? What happens if you get up and walk around? Heart rate should increase a little bit. When you sit down, heart rate should decrease a little bit. Same thing. But if we don't see any accelerations the whole time we're recording, then we might just go ahead and repeat the test just to make sure maybe the baby was sort of just inactive for that little period. But if that repeat test doesn't show any accelerations in that time period, then we might have to switch over to stress testing. And trust me, there's going to be a reason why you want to know this. When we're looking at stress testing, that means we're going to call what's called a contractile stress test. That means we're going to induce contractions on a baby that may not be term. All right, so if their non-stress test doesn't show any changes in the heart rate, they'll move to a stress test where they give them a very low dose of like Pitocin to induce contraction. What are the risks if we're inducing contractions and this kid's not term? I'll give you a hint. Preterm labor, right? That's going to be one of the risks. We must go back. That could happen with it. Of course, everything's being monitored. They're only going to do what they absolutely need to, and they'll look at a biophysical profile if they need to, as well, to look at how healthy that kid is looking at that point as well. All right, so these are the videos. I expect you to go through and look at the videos for the contractile. I think I have a good contractile and non-contractile stress test in there as well. And then I think one of them may talk about the biophysical profile. I wish we could do this together. Biophysical profile, I've already been talking about a lot. So this is good for you to know and understand. It's not something we covered when I was in school, but it's useful out there if you're doing high-risk deliveries in labor and delivery. This is good because it sort of scores how healthy the baby is, their biophysical profile. So these are the things it looks at. It looks at fetal breathing motion, the baby moving, right? Their tone, how active they are, their reactive heart rate, right? As well as their amniotic fluid volume, right? Okay, so those are the four things it looks at. So the higher the score, the better. So if there's no fetal breathing motion right up here, there's no fetal breathing motion, that's a bad score. That means the baby's biophysical profile is going to be scored lower. So here's the thing out there. I'm not going to ask you guys to score biophysical profile and memorize this chart. But I do want you to understand, if you have to go to a delivery or if someone tells you, hey, this baby's biophysical profile is low, right? They give you a number like 4 or 7 or whatever. They give you a low number, then that's a sign that this baby's not doing well. That means their transition to extrauterine life is going to be more difficult. That means you're going to have to be ready for more interventions, right? So I'm here to help you. If you go to a delivery and they say their biophysical profile is 4, why are we here, right? When you go to delivery, you're pretty much supposed to know why you're there. And if they tell you they have a poor biophysical profile, right? They say their biophysical profile is 4 or 5. Right, that's a bad sign because each one of these is scored 2 for perfect. So a perfect score, 2, 4, 6, 8, 10. A perfect score is 10. And if they tell you the score is like a 6, right, something's going downhill. Some of the deliveries, the emergent C-sections we've had to do are babies that had very poor biophysical profiles. So this is just something I want you to be aware of. I want you prepared for this. I want you to know what it means. If a baby has low amniotic fluid volume, It's a bad sign, right? We talked about that with hypoplasia, pulmonary hypoplasia, and that's a bad sign. So it's important that you pay attention to that. Reactive heart rate, that could be a sign of infection and health, especially the baby's premature rupture of membranes. Fetal tone, do they flex and move their limbs? Fetal tone is a big thing. Like, do they have a muscle issue? Do they have the ability to move? Is there a nerve column? Is there a spinal cord issue? Is there, right, something that goes on, right? Is there periodic limb movements? We need to make sure that these babies are moving healthily, and having a poor biophysical profile is a sign that you probably are going to need more intervention for that delivery. All right, hopefully I got you into the advantage of knowing a biophysical profile, not, like I said, memorizing it and scoring it, but understanding what it is and why it's important to you, right? Hopefully you at least get that part. Fetal heart rate, when we're especially going through delivery, they'll either use the external abdominal transducer or the scalp transducer. Don't let the scalp transducer sort of freak you out here. The scalp transducer, when you're looking at it, is just this little thing. It turns like a quarter to a half turn, and it goes in just to the very top part of the scalp, and that's what we're seeing down here in this part. And especially if we can't get a good reading externally with the uterus to heart rate contractions, and we think the baby might have some issues, that might be something they do. So if you do see this, usually they'll snip it at delivery, and then you might have to do like a quarter turn to take it out. Just be communicating with your care team, especially when you're doing this. But so here's the thing. If they're using the external abdominal transducer, they're unable to pick up a heart rate, what's going to be the next recommendation to look at baby's heart rate during this delivery? You're going to want, if they're unable to pick up this one, you're going to want to move to this one, right? Move to the scalp transducer. If they really need to look at baby's heart rate, the next best thing to do besides the external one would be to move to, or suggest, or ask, what are the thoughts on a scalp transducer? You might want to remember that later. I'm just saying. So when we're looking at this fetal scalp monitoring, we can look at the heart rate there. We can also take a sample of blood like I was talking about earlier and look at the pH. If it's above 7.25, we're doing pretty good. But if it's below 7.15, we're in severe acidemia. In other words, the baby might be hypoxic, which would then tell us as the delivery team to attempt emergent or urgent delivery with that situation. So that's a sign that the baby's having physiological stress and needs to be delivered sooner than later. So this is going to be an important thing for you to remember. If it's less than 7.25, that's a sign that they had stress in utero, and it could be a sign their cord compression or whatever is going on, uteroplacental insufficiency, is causing their distress, and we might have to deliver that kid sooner than later. GP scoring, you'll see this a lot. Gravida para, gravida is how many pregnancies they are. Prima gravida means their first pregnancy. And mom will usually dilate like 1 centimeter per hour. And in practice, that's sort of all over the book. Sometimes they'll be at 3 centimeters for like hours, and then they'll be at like 9. It's just so random sometimes. But when you look at it, this the prima gravida means it's their first pregnancy, first delivery. When we're looking at, and that might be a longer delivery. When you go to those deliveries, para means they've had completion of pregnancies. So prima para means they've delivered their first baby, right? Nulliparity means they've never given birth. And multiparity means they've given birth multiple times. So if someone has a GP score of 2 to 1, GP of 2 to 1, well, they've been pregnant twice. They've had 1 completion of the pregnancy. So they're probably, after that kid is born, they'll be a 2-2. Right? If we're assuming that they complete that pregnancy, that'll be a 2-2 score. So if you see a GP score, that's what they would call it, is the gravidoparity score. That's what we're looking at, is how many pregnancies to deliveries. In theory, if their GP score is off, let's say they're a 4 to 1 score, and they're not pregnant with triplets. If they're a 4 to 1 score, that could be a sign that you might need to gather more information, like they had previous unsuccessful term deliveries, so on and so forth. So do they have previous preterm babies? Was there miscarriage? Things like that. So that's, in theory, could be a sign that there could be a high-risk labor or high-risk pregnancy if their GP scores off, in theory. All right, mode of delivery is going to be important. Breech is going to be unique. Almost everything can go vaginally except for transverse. That's what you're looking at here. Transverse babies are C-section babies unless they convert the baby. And I think I have some YouTube videos of VERT. ECV, external cephalo version, and you guys can look that up on your own as well. When you look at a version, they'll usually put hand pressure on this side and hand pressure on this side and help sort of swirl the baby to get their head down. Obviously there's risk with that. It's called verting or ECV. And you guys can look at the videos. I think I put some in there. But you can deliver a baby breech, and breech can be footling, where both the feet are coming out first, or it can be frank breech, where the butt's coming out first. So those babies can still go vaginally, technically. You might have some issues where, like, their collarbone might get caught up in there and things like that. But transverse cannot go vaginally. So those kids might have to go C-section, especially. C-section or cesarean delivery is considered high risk just because it's not the natural way for the baby to come out, and it's high risk for their lungs. These are all videos. I think I have some C-section videos, some regular delivery videos as well in here. Hopefully we'll have time at some point to watch these together. It's up to you if you want to watch these. It's okay if not. So it's more important that you understand why you're there, what those things mean to you. With C-sections, you do have to be careful. The baby can get nicked every once in a while, and we'll talk about that in the next ones. But breech, frank breech, the kid could be born sunny side up, which is not a big deal. That means their head's pointed towards up. If mom's lying supine, their head would be and their face would be up as it comes out, the baby would also be supine as they come out. How about that? So if mom's laying supine and baby's coming out supine, that would be sunny side up, where their face is up, right? They're facing up. But normally they should be face down. They should be prone if mom's supine during delivery. European deliveries, you'll go to those maybe. Where mom's sort of on all fours, like what you've seen in that video for in the womb. That's a European style delivery, or mom's sort of on, standing up or on all fours and delivering that way. So there's just different methods to align the birth canal to the right place for the baby to come out, and that's the whole thing. If baby has to go through a big curvature, a big angle to go down and be pushed down against that soft tissue, it's going to be harder for that kid to be delivered. So a lot of it's about aligning the hips and the pelvis to get that kid the right angle to come out. And sometimes mom can tear, and so in order to avoid that, they can do an episiotomy. And episiotomies, you'll notice once they do the episiotomies, you'll see that kid come pretty quickly. So just be aware, if you're at a delivery and they do an episiotomy, that kid might be coming pretty darn soon. All right. Risks for assisted delivery, so C-section. So what are some of the risks? TTN, transient tachypnea, the newborn or neonate. Baby doesn't get that thoracic squeeze, and we already talked about that thoracic squeeze being important for the fetal lung fluid, not only to come out, but also for that first breath, to reduce PVR, to establish FRC. All that good stuff, which reduces pulmonary vascular resistance, which should help close the PDA. So obviously those are all positives. Well, with C-section, we don't get that. All right, so something that can put that baby at higher risk for RDS, right? Because they have that fetal lung fluid that's still left over, that's sort of diluting the amount of surfactant they have in there. Other things, you'll see this every once in a while. The baby can be nicked by the scalpel. So once they get to the uterus, usually they will tear. They'll make a small incision in the uterus and they'll tear the uterus. The idea there is you're making striated edges, right? So if you cut something, it's going to be a smooth cut. But if you tear something, it's going to be a rough, jagged cut. So a rough jagged opening. The idea there is the reason why they want to tear the uterus is to create those striated jagged edges, because when those jagged edges heal, it's going to make a stronger scar compared to a smooth edge. So when we have those jagged edges that heal, it's going to make a stronger scar. So if they attempt a VBAC or a subsequent pregnancy, the uterus should have a lot more integrity. So you'll see that. But when they might be going through and the baby might be really close to where they just make that initial cut, a baby could have like a little bit of a nick. And I've never seen it be serious. You just might have to hold pressure, just like an ABG. You just hold a little bit of pressure on that site, and usually the platelets will take care of it. So maternal bleeding, of course, still can happen. Maternal blood clots, of course, with any delivery. Maternal infection, surgical injury, especially bladder, things like that. Increased risk for future pregnancy. We already talked about a VBAC and possible uterine rupture with a VBAC. Possible, right? Like I said, statistically it's low, but it's just something you should be aware of. All right, when we're looking at vacuum extraction, and I think some of those videos were vacuum deliveries, obviously a scalp wound, we put this little thing on their scalp, pump it up, and then mom pushes, and as she pushes with the contraction, they're going to pull this little thing. So it doesn't actually put a lot of pressure on the head, it just helps move the baby more efficiently through the birth canal. So the issue here that you might have is a shoulder getting stuck. It might cause injury to the brachial plexus, or the collarbone might be stuck and fracture. Skull fracture could in theory happen. Have I ever seen it? No. Bleeding within the skull, of course, when you're putting the suction cup to the top of their skull, of course they can get a hematoma there. Increased pain for mom. So all this stuff down here is going to be mom. All the stuff up here is going to be baby. So baby. And this is going to be all mom stuff. We're looking at both of these things: increased pain, tears, wounds, difficulty afterwards, anemia with tears. Muscles and ligaments could get weak from not having that ability to stretch and accept the baby coming through the canal. You're sort of forcing those things open instead of letting them stretch naturally. It's not good, right? So it could weaken the PC muscles, pelvic floor muscles, and then that's when we might see things like organ prolapse, things like that could happen there. So those are all things that these people are aware of. It's something that they're going to take that risk versus benefit analysis in. This must be the forceps. The forceps delivery, facial injuries, and I think some of those videos were facial injuries. Facial palsy can happen with this, and this is where they put sort of one forceps in there, they curve another forceps in there, and then when mom contracts, very similar to the vacuum, when mom contracts and pushes, then they're just going to pull with a little bit of pressure to help the baby advance more progressively during the delivery. So I say these things, so you might get called to a delivery and you might ask, why am I here? Why am I at this delivery? And they might say, hey, it's a forceps delivery, or hey, it's a vacuum delivery. So I want you to be aware of, like, oh, facial injuries. I need to look at the eyes, make sure those are looking good. Make sure the skull's looking good, right? Make sure the baby's not having any problems like seizures or anything like that. So these are all just things you should be aware of, because most of the time the people that are going to be doing these procedures are very experienced with them. So these are all just risks that can happen. It doesn't mean it will. So when you're going to these deliveries, and this would be the baby stuff up here, and then this would be the mom stuff down here. So when we're looking at this, these are all things that you just should be aware of, that they are aware of this. They just think that there's more benefits than risks when they're doing this. In other words, babies having a lot of issues, their tones are down, their heart rate staying down, they have late variable D cells. Maybe we need to go ahead and get either a C-section or the baby's too far in the birth canal. Maybe we'll go ahead and do a vacuum delivery, right? A vacuum assisted delivery. All right, so this is what we're looking at when the baby's coming out. So station. Station is how far the baby is up in there. So if you go to a delivery or the L&D nurse tells you that they're -4 station, they're pretty far up there in the pelvis, and so that baby hasn't sort of dropped yet. And when we're looking at a baby that's +3, and they're looking at how even they are with the pelvis there. When they're +3, that baby should be pretty much crowning and almost ready to come out at that point. So that sort of tells you how soon that kid is, or why that kid, if that kid's still at -4 station and they're pushing and that kid's staying up there, that might be a CPD, where their baby, especially if they're at a 0 station, that baby's head might be too big to come through that pelvis. They might have to go do a C-section because there's cephalopelvic disproportion. In other words, the baby's head is too big to go through the pelvis, right? So it's got to go through the pelvis. These are all pictures of a complete breech, where the kid will be both feet and legs, or you could have a footling breech down here, or a frank breech where it's just the butt first type thing going on as well. So all those things are possible, and all those things can be delivered vaginally. Just puts the kid at risk for, like I said, collarbone issues and brachial plexus issues. So you got to watch those on the kid. If there's something abnormal about their arm mobility or anything like that, you got to watch that when you're at that type of a delivery. All right, so let's talk about preterm babies. So technically, as far as preterm babies are concerned, preterm babies are anything that's less than 37 weeks can be considered preterm. So I know it's sort of a broad definition, but anything less than 37 weeks is premature, preterm, same thing. And when we're looking at this, there's sort of severe prematurity and then late preterm. So severe prematurity was going to be less than 28 weeks. When we're looking at, and that's severe prematurity. Remember, we can go down to 23 weeks on this as well. So less than 28 weeks is going to be severe prematurity, and then a kid could be regular premature, I know, and then a kid could be late premature. Late preterm deliveries are going to be your kids that are, I think it's late preterms are between 34 and 36 weeks. So here, let me write that down. Less than 28 weeks is going to be severe prematurity. 34 to 36. Oh heavens, 34 to 36 weeks is going to be your late preterm. Now, late preterm babies, these babies usually have the most issues with just, like I said, blood sugar, temperature control, a little bit of blood sugar temperature control. They might have like a little bit of like fetal lung issues, not much of baby lung issues. Like they might need like 24 hours of CPAP. They might be like the little TTN baby, but usually it's temperature, blood sugar control, and some feeding issues sometimes, like nippling a bottle feed, things like that, or breastfeeding. They might have some troubles with that. So the late pretermers, not as much as the severe pretermers. The severe pretermers, which are less than 28 weeks, so a big thing we're there is head bleeds. Head bleeds is a big thing because their vascularity of their head is so immaturely developed that they could develop a brain bleed. And of course, brain bleeds on any age for any human is a very bad situation. And we'll talk about more about intraventricular hemorrhages or brain bleeds down the road. But brain bleeds, GI issues, because their GI system isn't supposed to be used yet. They're supposed to use mom's nutrition. Lung issues, of course, especially if they're only in their canicular stage in this severe. They're severe. Remember we talked about the lung development or the fetal lung development. If they're in that canicular stage, they're going to have a lot of issues. They don't have a lot of surface area. They can destroy a lot of their lung tissue as well. So what are some of the causes? And we talked about this at the beginning of prematurity. So when we're looking at the different causes of prematurity, that's something that you just want to be aware of. And infection was one of the big ones that we were looking at. Infections is going to be a primary thing that can be a preterm situation overall. When we're looking at infections tend to be something that we take very seriously, because those babies that are preterm, if they have an infection as well as being preterm, their ability to fight off that infection can be very poor. So you need to be aware of the infection, but there are other things like smoking. We talked about smoking be a big risk. If the mom's overweight or underweight before pregnancy, that can be a big risk. If they didn't get good proper prenatal care and there could be something going on, that could be a risk. If they're drinking alcohol or doing street drugs during pregnancy, that can be a risk. If the mom has high blood pressure, we talked about that preeclampsia, diabetes, if she already had blood clotting issues or infections, if a baby has certain birth defects that can also cause premature delivery or labor. In vitro fertilization has also been associated with it. Babies, if there's multiples, twins and triplets, we haven't even talked about that. If there's twins or triplets, they might be 34 weeks along, but they're all mature, right? When we're looking at multi-parity, if there's a history of premature labor, this baby also might have that same issue. Or if they even got pregnant too soon after their previous baby. Those are all things that could cause a high risk preterm labor or delivery for the next baby that we're looking at. Trauma, right? Trauma could also cause this as well. We had a mom that was in a car accident early third trimester of pregnancy. I think that kid was around 30 weeks or so, and we had they were doing chest compressions on her, and we had to do a C-section right there in the emergency department. So different things like that. All right, how do we stop there? How do we stop labor? Well, there's drugs called tocolytics, and tocolytics help stop labor. So there's two big drugs that help stop labor, and we'll go over it more in the other presentations, but mag sulfate is going to be the big one. It's a smooth muscle relaxer, and it helps let the uterus sort of stop contracting altogether. It's also great for those moms that have premature hypertension or preeclampsia as well, right? Remember, it's neuroprotective as well. So that's going to be one of the big medicines that you'll see them use out there. So tocolytics are going to be the category there. If we can't stop it, what are the risks and the outcomes? Remember, there are big risks with brain bleeds, big risks with BPD developing RDS and BPD, developmental delays, big time. That proprioception that we talked about, and they talked about in the womb video as well, that can be a big issue. They might need physical occupational therapy. They might need physical support. They might have issues with like brain bleeds, developmental issues. There's some other things out there that can happen as well, but the big goal overall is if we can get a kid past 32 weeks and it's safe to do so, that's the unofficial goal, right? Obviously, it'd be great if we can get a kid to 37 plus, but if we can get a kid to 32 weeks, as far as the current evidence goes, you're doing great. All right, post-term, this is a thing that's out there. So this is anything greater than 42 weeks in gestation. Can you imagine 42 weeks of, I don't know, that's a long time to be pregnant. So anything greater than 42 weeks is going to be considered post-term pregnancy. That's like 294 days, if I'm doing the math right. That's a long pregnancy. So gestation, that's a long gestation. What are some of the causes? Well, this is where it can be a little bit different. Usually it can be a miscalculation in the gestational date. In other words, they go from mom's last menstrual cycle, and they might have just miscalculated there. Now, understand ultrasounds are much better at sort of calculating where a kid's at. So that's going to be something they'll look at. So miscalculation can do it. But if mom also has previous post-term pregnancies, in other words, the last child had to be induced, this one might have to go post-term as well. Obesity has been associated with post-term babies. And then there's something called a sulfatase. There's a deficiency that can happen in the placenta where it doesn't allow the baby to sort of signal its maturity to mom, or to let the baby be mature, and that can also cause a post-term delivery. Now, I've seen that once. I don't know how common that is out there. So if a baby is post-term, how do we start it? Well, that's Pitocin, right? Or we schedule a C-section. So they'll go in for an induction of labor, and then hopefully the baby is delivered and is out of its nice little confines of the whirlpool that it was hanging out in there. And what are some of the big issues with it? What if we can't start it? What are some of the risks? Well, hopefully we can C-section if we need to. But some of the big risks are malnutrition, right? Malnutrition is going to be one of the big risks that we see. The placenta will stop usually pulling nutrients from mom. It'll be like, I'm done with my job, and it start giving up, and so the baby hasn't been delivered yet. So we can see the baby actually decrease its nutrition. The baby actually starts to become peely. Their skin is like peely and sort of like after a sunburn peely type thing. I know I'm putting good images in your brain, right? These babies can have obstructive labor. In other words, they can be too big for delivery, like we talked about with CPD. They can damage mom with their delivery, because we're talking about LGA or big babies at this point. They might need an assisted delivery, like a forceps or a vacuum, if we're going vaginally here. They're more prone to have C-section deliveries post-term, which have their own risk of infection for mom, and of course baby having a risk for not having the vaginal squeeze. Postpartum hemorrhage can be greater because baby might have caused more trauma because of their bigger size coming through the birth canal. And of course infection as well, right? For both baby and mom when we're talking about this type of situation. So post-term kids are, even though they're not preterm, are still can be sick kids, and same thing with mom. That can still be a traumatic delivery for mom as well. So we just got to be aware of that.